All right, I see folks joining. Hello and welcome to this webinar, a conversation with county leaders about the 1115 waiver demonstration opportunity for reentry populations. My name is Joey Longley and I'm a senior advisor here at the Office of National Drug Control Policy. Today we'll hear from Dr. Rahul Gupta of the Office of National Drug Control Policy, Dan Tsai from the Center for Medicare and Medicaid Services, Gina Furman-Nickel, ED of the Association of Oregon Counties, and Sheriff Peter Katujan from Middlesex, Massachusetts. We'll have an opportunity for question and answer at the end, and you'll be able to use the raise hand feature. If you're selected to ask a question, we'll take you off mute to ask your question at the end of the presentation. First, I will hand it over to Dr. Rahul Gupta, the Director of the White House Office of National Drug Control Policy. Dr. Gupta is the first medical doctor to serve as the director of ONDCP, component of the Executive Office of the President. ONDCP coordinates the nation's $43 billion drug budget and federal policies, including prevention, harm reduction, treatment, recovery support, and supply reduction. Through his work as a physician, a state leader and a local leader, an educator and a senior leader of a national nonprofit organization, Dr. Gupta has dedicated his career to improving public health and public safety. I'll hand it to Dr. Gupta.
Thank you, Joey, and hello to everyone. Thank you all for joining us today for this very important conversation. As Joey mentioned, I'm the director here at the White House Office of National Drug Control Policy, and I'm here with Dan Tsai, the Deputy Administrator and Director of the Center for Medicaid and CHIP Services. I see we have county leaders from 38 states online, which is wonderful because our counties are critical to beating the opioid crisis, and having been a health officer in more than one county, I know that. And we're thrilled today to have two county leaders sharing their experiences. Sheriff Peter Katujan of the Middlesex Sheriff's Office in Massachusetts, and Gina Furman-Nickel, the Executive Director of the Association of Oregon Counties. Thank you both for being here. We're hosting this webinar because the priorities each county sets and the actions that you take have such a major impact on the health, safety, and well-being of your residents. And the Biden-Harris administration is working hard to make sure that you have the tools that you need to do the job. President Biden's American Rescue Plan sent money directly to counties to help shore up budgets, to avoid layoffs, and to make sure that police, firefighters, teachers, and nurses were all on the job when we need them the most. Now, his bipartisan infrastructure law is investing in county roads and bridges and airports and water systems, so much more. And when it comes to the opioid crisis, this administration is working to help counties respond and save lives. You may know that right now an American dies from a drug overdose every 5 minutes around the clock. And 3 of the 4 of these deaths involve opioids, mostly fentanyl. And the burden of responding to this crisis largely falls to you, the counties and communities. So we've taken a number of actions here to help ease this burden, and I want to talk about a few. For instance, just a year ago, only 40% of the counties had a medical provider who could begin treating patients with buprenorphine, the treatment for opioid use disorder. So, what do we think that meant for people who didn't live in one of those counties, right? They had to drive sometimes hours to an addiction specialist. And you know what? They couldn't always get there. I've seen personally this challenge with my own patients in so many, in Covington County in Alabama. I've seen that even in Nashville area. I've seen that in West Virginia across my career. And I've had patients who have died in my arms in the emergency department overdosing because they never made it to the specialist. And I didn't have the ability to prescribe them treatment. I could write them prescriptions for opioids, but not treat them because I didn't have the extra license. So last December, President signed a law that did away with this extra regulation of the federal government on this. And now every single county, every county has a prescriber who can begin patients on this life-saving medication. We've gone from 129,000 prescribers to almost 2 million overnight. Now, we've also introduced a number of state model laws to help communities respond to the opioid crisis. Once again, when I was a local and state official, I have to create the wheel every time. But now these state model laws that can be applied at county levels as well, including one to help make sure settlement funds from the various litigation actually go towards helping people affected by the crisis. And they are available on our ONDCP website. Now, additionally, I'll tell you that we've been working to saturate states and communities with naloxone, the antidote for opioid overdose, and nearly 9 million doses have been bought by community with federal dollars last year. And to date, we've prevented more than 500,000 overdose deaths, 500,000. So we know the more naloxone that is available, the more lives will be saved, as long as it's available and affordable and accessible. Now, ONDCP is also partnered with the Department of Transportation to develop a non-fatal overdose tracker updated in real time to help communities like yourselves identify hotspots and respond with life-saving services. This dashboard is available publicly in near real time, and I hope you get to check it out and see what the response rates are and who's getting the naloxone in your community and who's being transported to hospital. But there's still so much more to do. Let me give you an example of that. There's a population amongst us often doesn't get enough attention or support when it comes to the crisis, and you as counties are paying the bill for it, and taxpayer dollars from the taxpayer dollars. And that's the nearly 2 million Americans who are incarcerated any given day in federal, state, and local facilities. We know that somewhere between 60 and 80% of the people who are incarcerated in custody are there for reasons related to drugs, up to 80%. Many need treatment for substance use disorder, but most do not get it. Now, we all know today that addiction is a disease, just like cancer or diabetes. Can you imagine telling people with cancer that they can't have treatment? Can you imagine withholding insulin? It'd be a death sentence. But the same is true for people with addiction or withholding treatment, unfortunately. In fact, there's a study that found that people re-entering society, because 95% of the people today, 2 million that are in, will get out. We know that when people re-enter society from a carceral setting, they're more than 120 times more likely to die from an overdose in the first few weeks alone following the release. But we also know it doesn't have to be this way. And in a growing number of communities, it is not becoming this way anymore. I'll give you an example. Earlier this year, I visited Cameron County Jail in New Jersey, where I met an individual in custody named Freddie Flores. He's 38 years old. He'd been incarcerated on and off in this jail and others since he was 18 for 20 years for drug-related offenses. He'd been using Percocet for so many years, but he wasn't diagnosed with opioid use disorder till that day, January 4th of 21, the day he arrived in Camden County Jail. I screened him for addiction right away. And since then, he's been getting the treatment through the jail. And now Freddie can see a brighter future for himself. He's excited to show off to his 2 sons. So he told me that he's got kids, boys 18 and 9, and that he's changed. And Freddie told me that he's looking forward to this new beginning of recovery, and he's not coming back to the prison, to the jail. So folks, this is about turning what once looked like endings for people into new beginnings, new opportunities, and fulfilling lives. And in turn, they'll make our community stronger, and it'll save money at the end of the day. And that's exactly what I want to see in every criminal justice setting across America. And this is why we've announced earlier this year that states can now apply to use federal Medicaid funding to treat people before reentry and set them up for achieving recovery once they've released. People can begin treatment while in custody and get a warm handoff to services in the community. And I've got good news for you to share. So far, 16 states have applied and 2 have been granted the waiver, and we expect to see more to follow soon. And I want you to know that the federal government is walking the talk here. Right now, we're working to make sure that every one of the federal prison facilities nationwide offers medication for opioid use disorder on site, every single one. So I encourage you to do the same for your county jails, and to encourage your states to apply for this waiver to make it easier and to adapt our model laws. You know, these actions can be the difference between life and death for your residents. And having been, like I said, working at county level, I know the sheer burden, financial burden that goes of the jail population and managing that on your budgets, but also that of overdose deaths of working age people and reincarceration, as well as lack of workforce. So this is a simple one. It's common sense. Let me end it by this. You know, President Biden has said this earlier this year that, quote, "We have an incredible country, and there's nothing beyond our capacity if we do it together." And we're looking to the counties as they are the key to getting it done, close quote. So thank you for being here with us here today. And thank you for your leadership and your work every single day. With that, I'll turn it back over to Joy Longley. Joy.
Thank you, Dr. Gupta. Next, we're going to hear from Dan Tsai. Dan is the Deputy Administrator and Director of the Center for Medicaid and CHIP Services at the Center for Medicare and Medicaid Services, where he leads the center in addressing disparities in health equity and serving the needs of individuals and families who rely on these essential programs. Before joining CMS, Tsai was the Assistant Secretary for Mass Health and Medicaid Director for the Commonwealth of Massachusetts, serving for 6 years, the state's longest serving Medicaid Director in nearly 2 decades. So I will hand it over to Dan.
Thank you, Joanne. Dr. Gupta, thank you for that kickoff, and also the very extensive partnership our teams have had in trying to tackle some of these issues together, working with states, counties, sheriffs, and a range of stakeholders. So I'll just say a few things at the outset here. First, thank you all for being here, your interest on this topic. I'm gonna, before I get into our Medicaid 1115 opportunity around reentry for incarcerated individuals, I just want to touch on one broader thing, which I think many folks will be spending time on. As an administration for Medicaid, we're highly focused on coverage and access, and making sure we're holistically addressing the range of needs for the folks that we cover. And certainly we have a lot of exciting things that we're thinking about for how to make access more tangible. One of the most immediate pieces on coverage that I just have to take a moment to mention. We, as I think folks know, we are undergoing Medicaid renewals across the country, which were paused for 3 years during the pandemic, during the public health emergency. And every state is in a slightly different place in the cycle. There has been an extensive amount of work from a federal, from a state, from a county, from a partner standpoint, but it is a really big deal. And we know that not everyone will maintain eligibility for Medicaid. And in those cases, we want to help make sure that people are successfully transitioning to all sorts of other coverage, employer-sponsored coverage, free or very low cost coverage through healthcare.gov/marketplaces or Medicare in some cases. And we're also taking our federal oversight responsibilities very seriously, making sure we're ensuring that states are following the various federal rule for Medicaid renewal. So this certainly intersects very much into what we're about to talk about, but I did want to note that for many folks on the ground who have already been, some of the counties conduct eligibility for their states. Thank you. We know it's just an incredible amount of work. And our goal is to help keep people covered, regardless of which form of health insurance, but we don't want people going uninsured. So for this topic here, I mean, some of the stats that Dr. Gupta mentioned are always very sobering. It's also a very exciting opportunity that we have, a long-standing set of discussions about how to more sensibly think about supporting reentry and transitions for Medicaid eligible individuals in carceral settings back into the community. The federal statutory long-standing prohibitions around Medicaid coverage for folks in carceral settings has led to this place where, as people are being are reentering into the community, you've got folks without medication support lined up, without a bunch of the social determinant and other social supports lined up, and a whole range of other things that will just lead to cycling in and out of the justice involved system, and a range of other things that are very common sense in nature for how we tackle. And so we have been really excited to work together with a range of partners, including Dr. Gupta's team, including Congress, which has given us some express authority here, and our focus as an administration around trying to break down some of these barriers. So if you're on this webinar or call, I'm assuming you know the details, but I'll do a tiny bit and hit on some of the challenges ahead and why we're excited. So we have a Section 1115 Medicaid demonstration opportunity, which states have to initiate, that will allow for coverage of Medicaid services during a 30 to 90 day reentry period for folks being reentering the community from justice involved setting. We've outlined, and it's a demonstration, a waiver of those longstanding statutory prohibitions I mentioned about having Medicaid coverage for folks in carceral settings. We've outlined, working with a range of states, counties, and folks in the correctional system, what some of the minimum requirements would be. So coverage of MAT, medication assisted treatment at a minimum, coverage of a full, leaving a carceral setting with medication in hand, not just a prescription to show up at your local Walgreens and figure that out. Case management support around a range of conditions, mental health, physical health, social, some of the health related social needs, housing instability, etc. Strong encouragement to do as much as possible around mental health, behavioral health, and a range of other things. And certainly we've said that states are, with their correctional partners, are welcome to go far above and beyond those covered services, but there is a minimum that we've outlined, and an expectation that in some cases, the enhanced federal funding coming in on that really is used to support a range of things, both quality of care within the carceral setting, as well as making sure that upstream and downstream on mental health and substance use disorder treatment in the community, those pieces are strengthened and bolstered so you're able to help across the entire continuum. We've got about a dozen states, a little over a dozen states with demos proposals before us. We've approved 2. We're very close to approving a few more, and we're deep in discussions with a range of states around how to meet the federal requirements for this. So it's exciting, it's common sense, and of course, there are details to work through. One of the most salient ones, especially I would note for this community here, is it is a big deal to bring together the correctional settings and Medicaid, the healthcare settings, which Medicaid is an entitlement framework and has a different set of standards around what people are entitled to and so on for services. Bringing those together, even how appeal rights work or different requirements in Medicaid of what providers need to be able to do, the sort of quality of care that must be guaranteed. In many cases, folks are embracing that with great enthusiasm, and even where folks are incredibly enthusiastic at the state, county, state correctional level, as well as sheriffs, all of that, there are real operational challenges. That is fine. That is good. That is us bringing disparate parts of the system together in a more common sense way. But I do acknowledge that that is real work. And a lot of the discussion with our state and other partners around how to make sure that we're providing a clear bar so that what is happening meets the bar. We are moving in the direction of strong quality care, and we're recognizing and understanding the range of practical realities and situations all across the country, all across states, across state, local, county level correctional settings, and the like. And so we're excited to hear from some of our partners shortly around this. So those are some things I just want to acknowledge, but we're very excited. We've spent time working with the states to say, how do we, to accelerate things, get states to, as quickly as possible, line up with some of the things we've already been able to improve, some of the things we've been able to run through at the federal level. We always say we're here to consider a range of innovative and one-off proposals, but those always take more time. So there are a number of states that have had 1115 demonstrations before us and are in the midst of modifying those to be able to accelerate. The final thing I want to note is a few months ago, I joined some state and county and correctional officials in actually going on site in one of our very large county-based correctional settings in the country, as they are in the midst of trying to implement this Medicaid reentry waiver. And it's tough and exciting. You see what people are trying to do. You see why this is common sense and why this is incredibly powerful and what it will do. And also the myriad operational, logistical, clinical, other considerations on the ground that make that difficult. So acknowledge that. I thank folks for that. And I think with that, I'm going to turn it back to Joey for what is exciting to hear from some of our local partners. So thanks.
Thank you so much, Dan. Next, we'll hear from Gina Nickel. Gina joined the Association of Oregon Counties team as executive director in March of 2020. In her role, Gina is responsible for leading the 35-county member organization and its partners in driving AOC's mission to unite Oregon's counties by advocating with a collective voice on statewide and national policy, exchanging ideas, building new leadership, and exercising exemplary leadership in public service, and enriching the public's understanding of county government. Gina is also a member of the National Association of Counties Commission on Mental Health and Well-Being, and has worked in mental health clinical and policy arenas for over 4 decades. Welcome, Gina.
Thank you, Joey. It's really good to be here, and I'm so glad that we're talking about this subject. It's been a passion of mine for over 40 years. I want to explain to you a little bit about what Oregon is doing with the 1115 Medicaid waiver specifically for reentry populations. Go ahead, Shalini. I'll just have you forward. The overarching waiver goal is to advance health equity. We really want to make sure in everything that we do with our Medicaid waiver, and especially for this population, that we're ensuring people can maintain their coverage. We improve health outcomes by addressing health-related social needs, which is so important, and ensuring smart, flexible spending for health-related social needs and health equity. And probably one of the more important things here is creating a more equitable, culturally and linguistically responsive healthcare system. Now, Medicaid coverage in carceral settings has been a challenge over the years, and we wanted to really make changes to the Medicaid eligibility for youth under the age of 21, including a suspension of Medicaid eligibility upon arrest, not termination, completion of redetermination without requiring a new application prior to release, because that takes a lot of time, and determination for new eligibility for youth entering a carceral facility with immediate suspension. And also activation of Medicaid eligibility 30 days prior to release for specific services. And that also is, as you know, drugs and alcohol play a big part of why people end up in carceral settings in the first place. And that's really important that we make sure that they have services as soon as possible. Next. So objectives of the reentry services is to minimize disruptions in access to care for individuals entering the community. Again, a huge barrier in the past, and we're really pleased with the Medicaid waiver that we can go forward with this. Also facilitating scheduling and coordination with providers before release by demonstrating proof of coverage. Improving coordination and communication between correctional systems, state and county systems, CCOs, that might be a different word to you. In Oregon, we can't call them ACOs, accountable care organizations, so we call them coordinated care organizations. So don't let that throw you. And community-based providers during release. Really improving connections are our goal between carceral settings and community services upon release to address physical health, behavioral health, and health-related social needs. We also want to reduce the unnecessary use of emergency department visits for non-emergency stemming from lack of healthcare coverage. We also want to reduce costly inpatient hospitalizations attributed to lack of access to preventative care. So we're upping our game on preventative care. Next. And so some of the CMS implementation milestones that we're working on, as you can see, increase and maintain Medicaid coverage, cover and ensure access to the minimum set of pre-release services, promote continuity of care, and connect to post-release services. We are doing that through the Oregon Health Authority, which is our state agency. Sorry, a train's going by. I'll try to speak up. Also, our correctional facilities, our county jails, our Department of Corrections, our healthcare providers, again, our coordinated care organizations, and also our behavioral health providers. Next. So looking at this implementation timeline, we are starting right now because we're working with all populations, because we want to set up the carceral population for, we want to set up everybody for success, but we've had challenges with carceral populations in the past, so we want to make sure we have everything set up right so we can move forward. As you can see, we're starting that right now, setting up the Oregon Health Authority staffing and project management. We did that this summer. Right now, we're doing the implementation planning and development phase. It's beginning with collaboration with individuals personally impacted by incarceration. We find peer support is very important. We're working with members of the Sheriff's Association, counties, correctional facilities, providers, the CCOs again, and partner state agencies. We, our service delivery will begin to go live. We say January 1st, 2025, you know, we'll work on it between January and June 2025, because we want to prepare for any glitches that might be, but we're really excited. And last page, because I know we've got lots to cover. I really want to thank the interim director from the Oregon Health Authority, Dave Baden, and the Oregon Department of Human Services Director, Fairboris Packeratz. I've been working with Fairboris for over 30 years, and Dave is the new interim director, and they have been fantastic to work with. We have a monthly local government advisory committee, and the state and the counties work together. There's more information on oregon.gov/1115 waiver renewal. please reach out to me if you have any questions. We'll have time for a little bit of questions later on, but we're excited to really go forward with this, and we couldn't be more pleased partnering with the federal government, the state government, and local governments in Oregon. Thank you. Back to you, Joey.
Right. Thank you, Edie Nickel. Next, we're going to be hearing from Sheriff Peter Katusian, who has worked on the leading issues in public safety and public health throughout his career as a prosecutor, a legislator, a professor, and law enforcement leader. While a state representative, Peter Katusian oversaw Massachusetts healthcare priorities as chairman of the Committee on Healthcare. He advocated for families and frontline workers on issues of mental health, school nutrition, nursing, opioid and tobacco use, suicide awareness, domestic violence prevention, pandemic response, crime profiteering, rape by fraud, and more. So we're pleased to welcome Sheriff Katusian.
Thank you, Joey, and a thanks to Director Gupta and ONDCP for hosting today. And Joey, especially to you, not just for that extra lengthy introduction of me, but for all of your efforts and your tireless and impressive efforts to organize this discussion. I've had the privilege of working with ONDCP for years. It actually began before my relationship with ONDCP with Michael Botticelli, who then became the director more recently. Michael and I worked together back in 2005. He was at the Massachusetts Department of Public Health, and I was chairman of the Committee on Public Health. And we actually worked on the very first OxyContin prescription drug commission. We had hearings throughout the state. We issued a report. In 2005, there were 525 opioid-related deaths in Massachusetts. Last year, there were over 2,300. The saddest part of that is that the findings of our report were as valid then as they are today, but they were never truly implemented, and that sadly rings true even today. Michael then visited our facility as the director of ONDCP in 2016 to tour our Matador, medication-assisted treatment and directed opioid recovery program, which I'll discuss today. I was also honored to present at the RX Summit twice with former ONDCP Director Regina LaBelle, who continues to be an invaluable leader in this space. And thank you, Regina, for all of your work. We've got great fellow panelists and Dan Tsai, the Director of Center for Medicaid and CHIP Services. We miss Dan here in Massachusetts. We really do, but we're really proud of the tremendous work he's doing at the national level, as well as Gina Nickel, the Executive Director of the Association of Oregon Counties. I served on the NACO NSA MIEP task force many years ago. The issue has remained critical for some time. Most of all, thanks to you that are in the audience and listening, and I hope you'll pay attention to especially some of the stuff I say today, because I think it's really important for us to get MIEP right as we move forward. I will say this right off the bat. We have a once in a generation opportunity to raise the bar of quality care for millions of Americans, save lives and save money for states, and most importantly, make our communities make them not just feel, but to make our communities safer and stronger through continuity of care. MIEP waivers could forever change the delivery of healthcare. I want to make sure I'm stating this clearly enough. They could forever change the delivery of healthcare, just like the Affordable Care Act did. This policy was implemented in 1965, the exclusion, and it's never changed since. The total U.S. prison population was just over 210,000 people that year, and jails were not even tracking total numbers. That has tripled since to about 610,000 people in prisons last year. And think about this, 10.2 million people released from jail in 2019. Think of what else has changed in society since then. So why does a sheriff care so much about MIEP? Think of all the health-related social needs outlined by Director Tsai and his team, and is seen in the most recent CMS guidance released to the field. I'd like you to just consider, for many of the healthcare advocates and policy advocates and public health people on this call, every social determinant of health is also a social determinant of criminal justice involvement. And that goes from mental health to substance use disorder, to trauma, to lack of education access, to homelessness and poverty, social network and healthcare network issues. And whether you are public safety or public health on this call, we all work with the very same population. Next slide, please. This is why corrections needs to be part of the conversation, truthfully, because we have treated this population for centuries. My office is historic in many ways. It dates back to 1692, when initially sheriffs were appointed by the king. We've got we're a large jail and large office. We serve 1.8 million people in Middlesex County. We've got over 700 employees. Our budget is about $75 million. And most of our efforts are focused at the intersection of public safety and public health. Now, let me just say this, as you might expect, we are the largest mental health provider in my county, despite world-class hospitals in Middlesex County like Harvard and McLean. And we should also understand that the largest mental health providers in the country are LA, Rikers, and Cook County jails. What does that say about society? Next slide. My road to becoming sheriff was untraditional. I started as a public defender and became a prosecutor. Then I became a public health policymaker. I led the Joint Committee on Healthcare. I oversaw the implementation of the Mass Health Reform, which became the template for the Affordable Care Act. I mentioned the OxyContin Commission that we had conducted and reported in 2005. Later, I led the Racial Disparities in Healthcare Commission in 2007. And as I mentioned with the OxyContin Commission report, sadly, these same issues in healthcare and criminal justice today exist, despite the fact that we knew then what we know now, and we still have missed the mark. All this gave me the experience to understand and navigate and appreciate intricate issues like MIEP. I've had the privilege to serve as a sheriff for more than a decade. I've been elected by my peers as president of Mass Sheriffs Association and president of Major County Sheriffs of America. I remain in my roots of public health. We've worked with researchers at Harvard, Brandeis, UMass, Tufts, and many other universities around the country to be published in academic journals on these issues. You can see on the right on that slide as well. I'm proud of that work, and I think it shows the substance of what we're doing here in Middlesex and across corrections. Next slide. Most important to me, however, is that I serve a population in need, a population in crisis. I consider this to be a noble calling. I mean this very sincerely, and I know my fellow sheriffs would agree. They feel the same satisfaction in providing supports and service for those in our care and preparing for their reentry, and they find a very noble calling in these opportunities that we provide for individuals and families. However, we cannot care for our population if we do not know what ails them. Now, in Middlesex, we rigorously collect data and use it to drive policy. You could say that I am obsessed, and we are obsessed with data here. I always say that vision without good data is just a hallucination, because you are flying blind. Even though you think you know what's going on, you really don't know what's going on, and you can't make the best decisions on what direction you should be moving toward. Now, these numbers are pulled from a live data dashboard on my phone. In fact, the very first bar, the percentage of individuals with a diagnosed substance use disorder, just updated. It's now percent higher, 47.03%. Probably just had a couple of folks just come in the door from court in the last hour or two. The left side graph shows overall numbers for major disorders. You can see that almost 47% have an already diagnosed substance use disorder when they enter our facility. Look at this number, 56.37% have an already diagnosed mental illness when they enter into our facility. 71.7% have a chronic illness ranging from asthma to cancer, psychotic disorders, as determined by the National Commission on Correctional Health Care. And 75.35% have an open mental health case with our clinicians currently. And some of that can be for those extra 20% or so, it could be anxiety and sleep disorders, things that naturally will occur in a correctional facility. On the right side is how those co-occur. These numbers have spiked during COVID. You can see that 92.3% of those with a substance use disorder also have a diagnosed mental illness. Imagine that. I mean, these numbers used to be around 75 to 78%. It's now 92.3%. 75.6% of those chronic illnesses are psychotic disorders as defined by the National Commission on Correctional Health Care. 73.8% have a co-occurrence with a diagnosed mental illness. Those that have a diagnosed mental illness also have a chronic illness, and 64% co-occurrence with a diagnosed substance use disorder that also have a chronic illness. This is what I meant when I say MIEP is a once in a generation opportunity for healthcare to provide for those that are in need, that are in crisis. It's a window of opportunity for significant impact on the most pernicious issues affecting society, and a chance to prevent trickle-down corrections, which, you know, I think you can all imagine that the children of those that are incarcerated have high rates of truancy and failures in education and sociopathic behavior in incarceration. So we can stem it at one generation. We can do so much for our families and our communities across this country. The notion that you can lose insurance even when held pretrial and presumed innocent of any criminal charge is unfair and wrong. And that's why I worked on legislation in Massachusetts to suspend versus terminate mass health benefits. I worked with Senator Markey on a legislative fix in MIEP through the 2010s and working on the Massachusetts MIEP waiver now. You saw Oregon's work detailed by Director Nickel. The Mass proposal is out for public comment now. It includes all Medicaid eligible adults for the last 90 days pre-release. It provides coverage for all DYS youth for the last 90 days pre-release, and coverage would be for specific services. Mirroring California's request for both youth and adults, and will be in line with CMS guidelines, which will include physical or behavioral health clinical consultation, which for us means correctional visits by community providers while they're still in our facility to prepare them for their reentry into their communities. Medication-assisted treatment and the medications, especially as they're leaving our facility and reentering their communities. Laboratory and radiology services. Really something important that we don't think much about: durable medical equipment like wheelchairs, diabetes testing strip, crutches. Again, we're speaking about a highly chronically ill population. And then lastly, that I'll mention here, but really importantly, is case management from healthcare navigators. It's really important to think about this as an in-reach and outreach. If you're going to do this, please don't let it just be an outreach. It's got to be an in-reach to build the relationships, build that trust, and then the outreach to carry them into the community. And by the way, each of the above mentioned pieces, the durable medical equipment, the MAT and all that stuff, the behavioral consultations, the navigator, the case manager will be the one that will also be identifying what is needed and and following up with the individual as well. That's why they're so important to the success of this program. The proposal also includes a startup infrastructure funding request and details on reinvestment, which I'll discuss more. Next slide, please. So what does this mean on the ground? How does this affect programming and treatment? To answer that, it would be helpful to understand some of the programming that occurs here in the Middlesex Sheriff's Office that occurs across the country in many other ways too, and especially for the health policy administrators on this webinar who may not be as familiar with what we can do in corrections. You can see from these recidivism numbers on the slide, I'm very proud of what we're doing in Middlesex as an example of some of the work happening in corrections. But I want to be very clear. I'm proud of the programs and the treatments that we have in the Middlesex Jail and House of Corrections, but you shouldn't have to come to jail to get good treatment. You should be able to get that in the community so that you never have to become justice involved or become incarcerated. But as long as you see those numbers hold, I have a responsibility to care for them and to support them in their recovery and their reentry. You can see the Massachusetts statewide number for recidivism is just over 32%, lower than many states. Our Middlesex Sheriff's overall number is 1/3 lower than that, as you can see on that graph. It speaks to the cultural impact of strong programming, quite honestly, I believe. Middlesex Sheriff's Office is recognized for several national program models. Quality programming with rigorous data collection has led to demonstrated reduction in recidivism. And MIEP can help enhance many of these efforts. So I'll just go through a couple of them with you to show you proof of this concept, proof of this work. Our Matador, Medication-Assisted Treatment and Opioid Recovery Program, we presented twice at the RX Summit with Regina LaBelle, been a national model for 2 presidential administrations. We're cited by NIC, NSA, NCCHC, NSA, ONDCP. We offer all 3 forms of FDA-approved MAT, both agonist and antagonist. We served over, well, almost 1,300 patients in 4 years. About 25% were starting medication-assisted treatment with us for the very first time. 1-year recidivism rate is 16.89%. The harm reduction, which is even more important, is very important as well, because 98% have not suffered a fatal overdose 1 year after release. That's quite significant because, well, we want to reduce recidivism. We want to keep people alive, right? And this is exactly what MIEP can do. We can do both, actually. Now, this is a 98%, not suffering a fatal overdose. By the way, we check these numbers with our medical examiner's office, so they're hard numbers. Not having a fatal overdose 1 year after release. This is despite the fact that the Massachusetts Chapter 55 report found that this population was 120 times more at risk of death 7 to 14 days post-release. So I think that number really speaks for itself about the success of using MAT appropriately. And by the way, the use of navigators, because the key to the success is the post-release navigators who help patients keep appointments, provide in-reach, to provide the one positive social network contact that they have in the communities, and keep people going, right? The one person that they have to tell something good that's happening in their lives sometimes is this navigator. This is an idea that I took from public health and applied it to public safety. And we're glad to see case management as part of the 2023 CMS guidance from Director Tsai on MIEP for this reason. So again, thanks again to Dan Tsai and his team. Our Young Adult Offender Unit, PAC, People Achieving Change Together, first of its kind in a jail setting, opened in 2018, a significantly different way of doing corrections. We all know in this on this call probably that the brain science of 18, 20 to 24, 26-year-old demographic is quite different. We think about insurance companies not renting cars to anyone under the age of 26. The actuaries figured it out long before the public health community kind of came down on this stuff, but now we see all the science. This is the most violent, impulsive population. We're using restorative justice model and community-based, cognitive-based behavioral therapies in this unit as well. And when you take a look at the reduction, is just that only 17.9% of this cohort have recidivated within the 1 year. By the way, this is the highest recidivating population across corrections, right? Because these are young people that fail to understand the consequences of their actions. They keep continuing to offend, and they're already starting in a hole once they are incarcerated. So getting young folks access to care could drastically improve, and each reaching a little bit lower, drastically improve our healthcare system costs down the line. Our housing unit for military veterans. We began in 2016 to target programming care for vets. This is also using CBT. It's a highly therapeutic community and unit in there. We have engagement from home base, Red Sox, Mass General, McLean Hospital, the VA, Veteran Services. It's been replicated across the country, more recently by Sheriff Mark Lamb in Pinal County, Arizona. And most all participants are eligible for VA cares, but they're barred from care that they earn through their service. This recidivism rate for 1 year is 14.57%, which is, again, remarkable, I believe. If any community provider claimed that they can improve healthcare for veterans, healthcare for young adults, healthcare for those suffering from substance use with a single policy change, it would be all that CNN and Fox News would talk about. And God knows, I'd like them to talk about something different than all they're talking about right now. These folks are the same as you or me. They have struggled with some those same health-related social needs. Sadly, these people found care in a treatment facility. And I want to say this, I think it's really interesting to hear. They found care in a treatment facility whose copay is a criminal charge instead of a financial charge. How sad is that for these people? Next slide. I want to end by reiterating something that Gina Nichols said. We must work together on closing this gap. This demonstration will fail if there are not strong cross collaborations going on throughout each of our states. Corrections will have to execute the implementation plan that health policymakers develop. If you are considering an MIEP waiver in your state, please bring everyone to the table early. This is really important. Sheriffs, departments of corrections, and their subject matter experts. People, another group to bring in, people with lived experience. This is another group, the consumers whose input is most valuable. What is their experience in these areas? How could we help them? Often we are too busy deciding what's best for people. We don't actually listen and ask the people that we are making these decisions for and on behalf of, and that would be helpful to everyone in this space. You may know healthcare policy, but you may not know corrections. There are a few moments within the MIEP process when you can and should engage. CMS requires states to develop an implementation plan and conduct readiness assessments of correctional facilities. So this is a requirement. Conducting this assessment prior to waiver approval is a great opportunity to engage with justice partners. For example, doing a tabletop exercise or sequential intercept mapping. I don't know how many of you folks have been involved with that, but it's really valuable, but it's really torture to go through. And it's the fine details and finding resources and in their whole the spectrum of their justice involvement, really valuable. But there are clear roles and responsibilities that are established through this exercise. In Massachusetts, we convened an MIEP coordinating council on which I sit. It's made up from representatives of our Health and Human Services Secretariat and our Public Safety Secretariat. It took 2 years to develop our proposal. We anticipate 5 years for implementation process. So there's a lot of time here, but we got to get together soon. It's important for everyone listening that everyone has to understand that states must have a reinvestment plan. I'm sure that Tsai, Director Tsai, would applaud me for just saying this, because everyone has to understand we have to have a thoughtful, thorough reinvestment plan ready to go to demonstrate to CMS how we will all use the new funding and how it will flow back into the respective jurisdictions. This is critical for all key stakeholders to be at the table for this discussion. So resource needs are identified by practitioners for a successful implementation. In Massachusetts, we have advocated for reinvestment in community supports and crisis response, embedding care coordinators from community providers into our facilities to make that transition much better. Remember, it's that in-reach and outreach, so the transition of care is seamless. And when you're also connecting people while they're inside, they value that, because not many people are watching out or caring for them while they're inside. It shows how devoted we are to our desire for them to have a healthy and happy transition and reentry back with their communities and families. Now, you can see that this issue is complex. It has taken 10 years of pushing on this while I have been sheriff, when it was no one else's priority other than some of the people on this call that understood what was going on, right? It's especially important to inform the public of the need to eliminate MIEP. This graphic shows some of our work: Boston Globe article in 2015, Washington Post op-ed in 17, Commonwealth Magazine op-ed in 2022. We kept pushing this when really it seemed like no one seemed to be paying attention or caring. Next slide. In closing, the field of corrections is at a significant turning point relating to this issue. I speak to sheriffs on this topic, and they are beginning to understand the sea change that is coming. Like in any organization, change can be difficult, and I don't know if it's more so, but it's certainly so in corrections. Change is really hard, and there are many unanswered questions that remain, and here are some for you to consider. And these are really important questions for you to consider. Number one, what are the staffing resources and the training that will be needed for the implementation of your MIEP? Number two, how will we facilitate care coordination with community providers? Number three, by the way, that care coordination, hugely important. because we've had programs here where we didn't coordinate with community providers as well, and they failed terribly because the community providers weren't on board. So they have to be on board, and there's got to be that direct conduit out to them. Number three, how do we develop reentry plans for those awaiting trial with no end of stay date? It's really well and good to say 30 days, pre-release for pretrial, or 90 days pre-release for pretrial, but no one really knows when pretrial population is getting out. But the corrections can help direct some of this conversation. The pretrial population is increasing and will put a strain on this new system and make it more important than ever. We did an analysis of our pretrial population by number of days held here in Middlesex Sheriff's Office. It's longer than I think we expected, but the average length of stay was 51 days, but that doesn't really capture the real churn. So what we did was broke it down by a few time periods that I thought would be interesting for you to consider when you're thinking about how are you going to plan for people reentering when there's no set date for them to finish their case, except for maybe a trial date, and even that may not happen on that time, right? So from 30% of our population stays 1 to 7 days. So a full third are a very short period of time. 17% range in days from 8 to 30 days. 12%, 31 to 60 days. 12%, 61 to 90 days, which is the mark, at least here in Massachusetts, 90 days. And then 29%, 90 days plus. By the way, understand that some of these people are being held for years pre-trial, especially if they have mental health issues that they struggle with inside here and with the court and with their attorney and everyone else. So that's a real significant issue with the mental health population here. Number four, how do we establish a system for submitting claims to Medicaid? Very important. We haven't had to do this. Do we need to be certified? Do we have to have a specialist in here? This is going to be a big change for us in corrections. And number five, what upgrades to your IT or your electronic medical record systems will be needed to coordinate care for returning systems? And we know there's going to be some, right? Now, each stakeholder at the table will have their own set of questions like this, which is why I can't emphasize enough. If your state is contemplating a waiver, start planning this process as soon as possible. I hope that this provides for some food for thought. Again, I thank you, Director Gupta and ONDCP, for hosting this great panel discussion. The insights and the leadership of Director Tsai and Executive Director Nickel, and of course, Joe Longley for all his hard work in making this a success. And a special shout out to Megan Noland of Major County Sheriffs of America and and all of my fellow Major County Sheriffs and their staff that are on the call today. Thank you very much.
Thank you so much, Sheriff Katujian. We've unfortunately, thank you so much for all of this substantive discussion. We've unfortunately run out of time for questions, but we will be able to answer questions over email. If folks could send questions to rsvp@ondcp.eop.gov, we'll route those questions to the appropriate people. I'd like to close today by thanking our panelists and all of our attendees today. Thank you so much for such an educational webinar. And I hope everyone enjoys the rest of their Wednesday. We'll be in touch soon. Thank you.